Okay, this is ALHS 1011, and this is now Module 5, and we will start with the respiratory chapter. Here are our learning objectives and a system overview. So the respiratory system is very, very closely intertwined with the cardiovascular system. In fact, sometimes we call it cardiopulmonary system, kind of joining the two. They go hand in hand. And you'll see that throughout this chapter. The main objective, you might think the main objective of the respiratory system is to breathe in and out. Well, yes, it is, and that is ventilation. But what the main objective is cellular respiration, and you'll learn the difference in this chapter. So jumping right into that, ventilation. Ventilation is the bulk movement of air down to the lungs. So inhale and exhale. Respiration or cellular respiration is really at the cellular level. It's a gas exchange, oxygen and carbon dioxide at the cellular level in the alveoli in the respiratory system. So external respiration is the movement of oxygen from the alveoli to the blood. So we'll move inhaled oxygen, we'll move that from the alveoli to the circulating blood. That's external. It came from the external environment. Internal is the movement of the oxygen from the blood to the cells. So both of those internal and external respiration comprise what is cellular respiration. So the components we have of the respiratory system, we have two lungs that serve our vital organs. We have an upper airway and a lower airway. We have alveoli, which are grape-like clusters, sacs that are filled at the end of our bronchioles, and they have a network of capillaries on them, and that's where the gas exchange, that's where cellular respiration happens, at the alveoli level. Then we have the thoracic cage, and that is our rib cage, our bony protective mechanism of the skeletal system, and that protects and helps us function. We also have muscles of breathing, so a lot of accessory muscles, our diaphragm, etc. Okay, here's a nice picture of kind of what we're talking about. We've got the nasal cavity, the pharynx, the larynx, we've got the lungs. At the end of the lungs, like I was mentioning, the grape-like clusters, you've got air spaces, and you've got capillary beds on the alveoli. And that's where the gas exchange happens. The trachea, if you were to do a transverse section of the trachea, you'll have cartilage rings, you've got air space, you've got respiratory epithelium, and some connective tissue. You see that respiratory epithelium has hairs, cilia, that also protect the airway. Here's a short video about respiration.
Respiratory and respiratory systems ensure that oxygen, which is necessary for cellular respiration, gets to the body's tissues, and carbon dioxide, a waste product of cellular respiration, is released from the body. Internal and external respiration are the two processes that keep all of this running smoothly. Let's start with external respiration, also known as gas exchange. The body's veins carry deoxygenated blood to the heart, which pumps it into the blood vessels of the lungs, or the pulmonary loop. When you inhale, the air travels through the trachea and the bronchi of the lungs to tiny air sacs called alveoli. These sacs are surrounded by capillaries, blood vessels with thin walls. Oxygen from the air you inhale diffuses from the inside of the alveoli to the blood and capillaries. At the same time, carbon dioxide in the blood diffuses in the opposite direction, moving from the blood and the capillaries to the alveoli. The carbon dioxide leaves the body when you exhale. Newly oxygenated blood from the pulmonary loop enters the heart and is pumped out to the body's arteries. Then, oxygen carried by the blood in the arteries diffuses from the bloodstream into the body's tissues, and carbon dioxide and other waste products diffuse from the body's tissues into the bloodstream. This is called internal respiration. Veins carry the deoxygenated blood back to the heart, and the whole process starts again. Want to learn more about internal and external respiration? WebSuite has.
Okay, so that's a good kind of overview video. Okay, so let's get down to the anatomy. The anatomy, the upper airway, we're going to talk about the parts and their functions. So the upper airway conditions the outside air. So we're trapping particles, we're warming the air, and we'll get into the functions in a second, but it composed of the nose, the mouth, and the pharynx, which has subsections, and the larynx. So those functions are, I mentioned, heating and cooling the air to body temperature so we're not shocked by what we're breathing in, filtering, humidifying. We get the sense of olfaction, so we're smelling things as we're bringing it in. It also has to do with making sound or voice and producing sounds or phonations. And then ventilation, that gross movement of air into the lower airways. Here's a cadaver side view of the upper airway. So we have here the nose. We have the nasal conchae, which is the nasal cavity right here. We have the hard palate of the mouth. We've got some sinus cavities, and then we've got this nasopharynx, part of the pharynx, the uvula in the back of the throat, the oropharynx, laryngopharynx, and the trachea. You can see the trachea sits in front of the esophagus. Okay, so the nose. Some people breathe through their mouths, call those mouth breathers. We're really meant to breathe through the nose. And the nose is semi-rigid. It's composed of cartilage and bone. And the nasal cavity has regions. So it's got a vestibular region, it's got a respiratory region, an olfactory region for smelling. The respiratory region, here's the three regions highlighted in color. So here's the vestibule right here. The respiratory region is where our air is warmed, it's moistened. We've got turbinates or bones here, scroll-like bones here. And the turbinates are going to warm and moisten the air, adding about almost a liter of water to outside air, to a percentage of 80% humidity. So that does that before it even reaches our lungs. I mentioned sinuses on the cadaver. Sinuses are air-filled cavities. They connect to the nasal cavity. We have paranasal sinuses. Around the nose are our paranasal sinuses. Our sinuses help us with sound. You know, if your sinuses are clogged, your voice sounds different. They help to lighten things in the head. Otherwise, our head would be solid, right? So it lightens the weight of our head and it warms and moistens the air. We are not born with sinuses, they develop. And that's why our facial features change as we age, is that we're developing sinuses. Okay, I mentioned the pharynx. The pharynx is the throat. So pharynx equals throat. And it's a hollow muscular structure behind the nasal cavity, okay? And it's lined with epithelial tissue. We have the part that is adjacent. So the three little sections of the pharynx are what that section is adjacent to. So the nasopharynx is adjacent to the nose. The oropharynx is adjacent to the mouth. Laryngopharynx is adjacent to the voice box or larynx. That's the larynx is the voice box. So here's our nasopharynx, and we have air trying to get through, right? We have, in this first case, we've got a blocked eustachian tube, we have got blocked passageways. But in the second one, we see a free-flowing air through the nasopharynx. It's the uppermost section. It begins at the nasal cavity. It's lined mucosa. In this section, we have adenoids, which are our pharyngeal tonsils. And we have a passageway to the middle ear called eustachian tubes. That's one of the reasons it's never good to suck snot back into your body. It's always better to blow it out, because if you are sucking it up, you can inadvertently cause an ear infection by bringing that mucus into the eustachian tubes. Okay, the oropharynx, the next section, center section, is located right behind the oral or buccal, which was the cheek, cavity. And this has stratified squamous epithelium. Air, food, and liquid pass through the oropharynx. We have tonsils that are part of the lymph system. We have the palatine that are on the sides, and the lingual tonsils. The final section, we've got the nasopharynx, the oropharynx, and the laryngopharynx. The final section is the lowermost portion of the pharynx, and it connects the larynx and the esophagus. And it has stratified squamous epithelium. Water, food, and air pass through this. Okay, the larynx I mentioned was the voice box. And let's see the best picture of it. These are kind of the cartilage processes of the larynx. It is a semi-rigid structure. So the larynx is semi-rigid. It's made up of all these, you don't need to memorize the types of cartilage, but it's made up of cartilage and connected with muscles and ligaments, and it allows movement of the vocal cords to control our speech. You have the thyroid cartilage, which is in the front, the anterior surface, right below the skin of the neck. And that's what we commonly call an Adam's apple. You have the cricoid cartilage that's just below it. You have the glottis, which I'm not sure we can see a picture of that. There's the epiglottis, opening that leads into the larynx. Okay, here's a transverse view of what I was saying. Here is the thyroid cartilage in front, then the cricoid cartilage. You've got vocal cords in this C picture. Vocal cords look like this. You have the epiglottis in purple, okay? The glottis, the hole, and the inner lining of the trachea. And I love this animation because it shows how food goes down the esophagus and swallowing, and that epiglottis is closing off the trachea so we don't accidentally inhale food or liquid. So during swallowing, the uvula and the soft palate are going to protect the nasopharynx. We've all eaten something, and I use the word snarfed it up into our sinuses, or snarfed it up into our nose where milk is coming out of your nose or whatever because you're laughing and you're eating. But normally, your uvula and your soft palate are going to protect the nasopharynx from food entering there. But if you're forcefully laughing, you can overcome this. Food normally, as in this animation, travels into the esophagus, and air goes, we want air in the trachea, food in the liquid in the esophagus. And that epiglottis closes off the trachea so that we cannot get air or food or liquid down there. So the epiglottis closes when we swallow to prevent food or liquid from entering the lungs. And this is called the glottic sphincter mechanism. That glottis closes tightly, forcing the food to enter the esophagus. And I thought this was cool too. Upper and lower airway. So the vocal cords, as you can see in the picture, are acting as a dividing line between the upper and lower airways. The space, between the vocal cords are called the rima glottis. Okay, so in the upper respiratory tract, we have the nasal cavity, the pharynx, and the larynx. At the point of the larynx is the dividing marker of where the lower respiratory tract starts. The lower respiratory tract resembles an upside down tree. It's called the tracheobronchial tree. And we have tracheal cartilage, we have the larynx, we have bronchi, and it looks like an upside down tree. Okay, the pleura. The pleura is similar to the pericardium. It is a serous membrane. It encases the lungs. It protects the lungs. It's fluid filled. And it prevents irritation of the lungs against the rib cage. Otherwise, we would have friction and irritation of the lungs moving with the movement of breathing against the rib cage. So the visceral pleura covers the lungs. On that side, it's covering the lungs. The parietal pleura lines the outside of the rib cage or thoracic cavity and the upper side of the diaphragm. Between the two layers, we call it a pleural space, and the fluid between is called the pleural fluid. Okay, this is a transverse cadaver photo. Let's see, we have the pleural cavity here, which would contain pleural fluid. The visceral layer of the pleura is going to touch the organ. It's going to touch the lung. The parietal layer, the parietal pleura, lines the rib cage, the bones. You can see that here, the ribs. We have a trachea, and from the larynx, so the larynx is a dividing factor of the upper and lower airways, the voice box. Then we have the trachea, and that's commonly known as the windpipe. And it extends to the 6th thoracic vertebrae. It's 18 to 20, depending on size, C-shaped cartilages. And it's the largest pipe. It's the largest trunk of the tree. It's the main trunk of the tree, the trachea. Okay, within the trachea, we have what's called a mucociliary escalator. They're epithelial lining, so that the trachea is lined with epithelial cells, pseudostratified ciliated little hairs, columnar cells. So we have these columnar epithelium with cilia on them. And each columnar cell has about 200 to 250 cilia on its surface. And those are hair-like projections that beat at a fast rate. Also, and you could see it in this picture here, are goblet cells in the trachea. Goblet and submucosal cells. So interspersed, we have produced about 100 milliliters. These goblet cells produced about 100 mLs of mucus a day. And mucus may sound gross, but it serves a very important purpose. One is a watery layer called the sole layer, houses the cilia. Okay. The top layer, the gel layer, has a more viscous, thicker, stickier substance that's going to trap particles, small particles. And this is kind of how the cilia and the mucus work together. I like this, like little tiny oars resting in that sole layer. And these things beat 1,000 to 1,500 times a minute and propel the gel layer, if you could see the yellow, right? It propels that gel layer, the sticky, mucusy, thick layer. It propels it and trap debris upward in about 1 inch per minute. It's moving it to be expelled. We don't want these things in our lungs. So the debris that gets will be propelled then into the oral cavity, and then we cough or swallow it. Now, for smokers, smoking paralyzes this whole mechanism, this escalator. So when you smoke, you paralyze this ciliary mucus escalator. So you're basically taking down the defenses of your respiratory system. Here are the airways and the lungs. So humans have a reserve about 4 to 6 minutes oxygen reserve. From the trachea, we have the right and left bronchi. From there, we have bronchioles. And from there, we have terminal ends called the alveoli. The alveoli, remember, have that capillary bed on them, and that's called an alveolar capillary membrane. And that's where the interface between the capillaries of the cardiovascular system and the alveolar surfaces interface. So this is where the cardiovascular system and the respiratory system kind of connect. So we go trachea, bronchus, bronchioles, alveoli. Here's the bronchi. So the trachea gets segmented, and we have an inner epithelial layer that has that mucociliary escalator. We have a middle layer that has smooth muscle, lymph, and nerve tracts. We have an outer layer that's more protective. It's got cartilaginous rings. The carina is where they bifurcate, so at the splitting point. Okay, the angle here. So this is kind of interesting. They don't branch off exactly equally in angle. The right main stem bronchus is a 20 to 30 degrees from the midline of the chest, whereas the left side is a 40 to 60 degree angle. So the right side, that lesser angle, because it's not branched off as much, allows more foreign bodies to get lodged in the right side accidentally than the left side. So if we were to choke on something and we were to bet which side it might be lodged in, it's more likely to be lodged in the right side. Bronchioles. So from the trachea, we have bronchus, then we have bronchioles, the medium-sized layer, the vessels or branches. These do not have that cartilaginous rings. They don't have that layer. And the epithelial layer becomes simple ciliated cuboidal. It no longer has, because it's further away from the trachea and the bronchus, cilia, goblet cells, and submucosal glands. Most of that is not present. And then the lungs, the rounded tops of the lungs are called the apex, and they're about 1 to 2 inches even above the clavicle. The base of the lungs rests on the diaphragm. The right is a little higher than the left because it has less of an angle. The medial surface of the lung has a concave like curvature, which we call the cardiac notch or the cardiac impression, where the heart fits. The hilum is the area where the root is attached, where to the main stem bronchus, the pulmonary artery, vein, and nerve tracts and lymph vessels. So here is the anatomy. You can see the cardiac notch right here for the heart. So the right lung has 3 lobes, superior, middle, and inferior. And we call the separation of them fissures. So you have the horizontal fissure, the oblique fissure, 3 lobes in the right side. The left side has 2, the superior and the inferior, and just an oblique fissure. The lingula is an area of the left lung that corresponds to the with the right lobe. The right lobe is larger, and 66, almost two-thirds, about two-thirds of the gas exchange is going to happen on the right side. So even though that angle is less, and we're more likely to aspirate something in that lung, and it's got 3 lobes, more of the gas exchange is happening there. Okay, so this is a nice picture of some of the sections of the lobes. You don't have to get this specific in this. Here's some bronchi, the right and left lung. Okay, alveolar ducts originate from the respiratory bronchioles. So the alveoli are the air sacs at the end. They are simple squamous epithelium. There's no cartilage down here. There's no smooth muscle, no mucus. We have 300 to 600 million alveoli with a total area of 80 meters squared. And at the alveolar surface, we have the alveolar capillary membrane. So this is where the cardiovascular system and the respiratory system interface. You have the first layer that's called the liquid surfactant layer that lines the alveolar. You have the tissue layer, the second layer, or is the alveolar epithelium. Then you have interstitial space between, and then the endothelium of the pulmonary capillaries surrounding the alveoli. So this is a pulmonary capillary lining the alveoli. I mentioned surfactant. That was in the first layer. This is very, very important, surfactant. Surfactant lowers surface tension. So it prevents us from overexpanding like a balloon and rupturing the alveoli. If you don't have surfactant, you have stiff lungs and they don't expand, they resist expansion, and they can rupture. Surfactant is one of the last things to develop in fetal development. So if a baby is born prematurely, they may be given artificial surfactant. So we have terminal bronchioles, we have the alveolar sacs, the alveoli, you can see the capillaries lining the alveoli. Then we have the thoracic cavity. We have the thoracic cavity is our bony cage. We have the mediastinum, which is the cavity that contains the esophagus, the heart, the great vessels, the trachea. So that area is called the mediastinum. And breathing in and out causes this entire cage to move. This is movable. Okay, we have a bony thorax. So we have bone and cartilage, and that is what we refer to as the rib cage. So, and that has movement on the chest. So we have the rib cage, the sternum, the thoracic vertebrae in the back. The sternum is your breastbone, and that's centrally located. And that has sections. The top of it is the manubrium, the top. Then the body of the sternum, or your breastbone, sometimes we'll call it. And then the xiphoid process is the bony tip. Your ribs, we have sections of them. We have 12 pairs of ribs. Numbers 1 through 7 are true ribs. True ribs mean they connect sternum to vertebrae, front to back, they connect. Pairs 8 through 10 are considered false ribs because they connect to costal cartilage of the superior rib and then the vertebrae. So they're connecting to cartilage and then the vertebrae. 11 and 12 are floating ribs, and they're in the back here. They have no anterior attachment, no front attachment. Just make sure I didn't skip one. No. Okay, so how do we breathe? We breathe in the nervous system, the medulla oblongata is responsible for breathing. You damage that part of the brainstem, you're not breathing. That connects to the phrenic nerve, which is actually what causes hiccups, the phrenic nerve, causing the diaphragm to contract. So I like this picture because it shows the medulla oblongata stimulates the phrenic nerve, which causes the diaphragm to contract. So it flattens during inhalation. It flattens and air can rush in. When the diaphragm relaxes after it contracts, then we exhale, pushing the air out. So in inhalation, the diaphragm presses all the abdominal organs downward and forward. And in exhalation, when the diaphragm relaxes, it recoils to a resting position. And you can see that in this animation really well. So inhale, we kind of elongate the lungs and fill them, inhale. And then when it relaxes and goes back to its normal position, we exhale. So inspiration is the active process. Inspiration, the diaphragm contracts and flattens, increasing the thoracic space, creating a lower pressure, air rushes into the lungs. Exhalation is more passive. The diaphragm returns to its resting state. It recoils back up to that curved dome, and it decreases and it kind of squeezes and pushes the air up and out. Increased pressure. Okay. So this is the order of airflow through the lungs. You have the pharynx, the throat, then the trachea, the bronchus, the bronchiole, to the alveoli. And this is a graphic showing when the diaphragm contracts or moves down, that's inhalation. It flattens, making more space. And then when this is actually showing more contracting. When it relaxes back, the air is pushed out. So here's at rest. During inspiration, the orange picture down here, that diaphragm flattens, more air can come flooding. When the diaphragm relaxes and recoils back to a curved position, we have expiration or exhalation. Normal respiratory rate is between 12 and 20, and that is controlled by the level of carbon dioxide in our blood. So if carbon dioxide levels rise in the blood, the medulla oblongata sends signals to increase the rate and depth of breathing. If we have too much carbon dioxide, we have acidic blood, acidic conditions, and but that's a decreased pH or acidosis. So regulating respirations. I mentioned that the medulla oblongata is the main center in the brainstem that handles respirations. We have stretch receptors, the pons, the cerebral cortex, and the chemoreceptors that provide us information about pH and CO2 and oxygen. So that's kind of how the medulla oblongata decides. The gas exchange, we know the right heart sends oxygen-poor blood to the lungs through the pulmonary artery. Oxygen exchange for carbon dioxide, we give oxygen to the blood, we take back carbon dioxide to be exhaled, happens at the pulmonary capillaries. And then blood from the left heart, that oxygen-rich blood, gets circulated to the body and we exhale carbon dioxide. And that's gas exchange. So external respiration. External, remember that diaphragm flattens, it's contracting. air rushes in with oxygen in it. With this external respiration means a gas exchange from respiratory system to cardiovascular system at alveoli to the vessel. Then our internal or cellular respiration, both of these are cellular respiration, but our internal part is when that circulating blood gas exchange happens between the vessel and the cells. Okay, some factors that affect gas exchange. Concentration gradients of the gases, membrane area, the more surface area, the more opportunity for diffusion. If the membranes are thicker, gas exchanges become difficult. We need it to be. Solubility of the gas. We need to be soluble in water in order to cross the respiratory membrane. So gas transport, how do we move gas around? If you remember that the red blood cells have a protein called hemoglobin, and when they pick up oxygen, they're called oxyhemoglobin. And then carbon dioxide is transported in the blood as bicarbonate ions. Hemoglobin is going to carry that oxygen around from the lungs to the tissues and then carry hydrogen ions back from the tissues back to the lungs. So acid-base balance. We always talk about hemostasis in, so when our normal blood pH is between 7.35 and 7.45. When it's lower, it's more acidic. So if we have too much, remember CO2 is acid. So when we have too much CO2, we want to hyperventilate. We want to get off some of that, blow off that CO2. So the medulla oblongata is going to tell the brain, it's going to tell the lungs, hyperventilate, breathe more fast, breathe more deep, get rid of excess CO2. And that should raise the pH. If we're in a state of alkalosis, so higher than 7.45, the medulla oblongata is going to do the opposite, telling us to hypoventilate. So slow it down so that we can keep the CO2 and lower the pH, keep the acid. Okay, our functions of our respiratory system, obviously to transport oxygen from the environment to the bloodstream, that's external respiration, and then to the cells, that's internal respiration. We move about 12,000 quarts of air a day in and out of our lungs. We need to remove waste, remove carbon dioxide, so it doesn't build up in our system and cause acidosis. The respiratory system functions for smell, acid-base balance, and then pressure gradients circulating our blood and lymph. Okay, this is the end of the respiratory system.